Welcome, everyone. Thank you for joining us for Region 11's monthly webinar series. My name is Brianna Ingeseth, and I am part of the Chapter Relations team at HFMA. So to kick off the webinar, we would like to take a moment to thank our sponsors: AmPlus, Commerce Healthcare, Progressive Management Systems, Parallon, Firm, TCF Capital Solutions, Harris & Harris, Extend Healthcare, Access One, HRG, AccuReg, Novus, Mail My Statements, Brault, Premier, Centauri, TrueBridge, Aberdeen Health, Patient Matters, Argos Health, RMC, Enable Comp, State, Sherlock, Eide Bailey, Softtech, OVAG International, and Vitalware. Your participation today is requested. There will be a live Q&A during the webinar, so put your questions in the Q&A pod. We'll also be utilizing the chat pod to share information and tips during the session. And now it is my pleasure to introduce Kiat Lam, Chair of the Reimbursement Committee for the Oregon chapter.
Great. Thank you, Brittany. Appreciate you kicking things off. Good afternoon, everyone. On behalf of the Oregon chapter and all of our Region 11 chapters, I'd like to extend my own welcome. I appreciate you all joining our webinar today. I have the privilege of introducing our speaker, Miss Virginia Ginny Gleason, who will be discussing the use of telehealth as this pandemic continues. As we all know, telehealth has become a critical pivot for our delivery system during the pandemic, and it will likely play a key role in the future of our healthcare delivery. So Jenny's insights into key issues related to billing, reimbursement, optimizing telehealth is both timely and relevant. So with that, a little background on Jenny. She's a senior manager in nThrive's advisory services group. Her consulting work is built on 25 plus years of experience working in hospital operations across all kinds of settings: academic medical centers, short-term acute hospitals, children's hospitals, and critical access hospitals. She's worked in case management, utilization review, compliance, and CDI. She's also spent many years practicing corporate law and representing hospitals and physician practices on issues related to healthcare regulations. Jenny holds a nursing degree, a bachelor's and master's in healthcare policy and administration, as well as her JD. Jenny, as I review your bio, it makes me feel like a big time underachiever, but that's okay. I'm good with that.
Jack of all trades, master of none.
Just a couple of quick housekeeping items as well. Brianna mentioned the Q&A. Yes, please do submit your questions through the chat box. I think some have already come in. We'll try to get through all of them towards the end. We're going to also send you a survey link. Certainly appreciate you sharing your feedback as we strive to continue to improve our education offerings. I think with that, I'll turn it over to Jenny. Thank you.
Thank you very much, Kat. I appreciate it. Welcome back for those of you that I was able to speak with at the Oregon HFMA chapter recently. Don't worry, the presentation has changed. Some of the information we'll cover again, but for the most part, we're going to be covering different information because it seems to be changing daily, and there are other areas that we can focus on. So Kat already introduced me and the alphabet soup behind my name. So I want to get right into our discussion for today. So something that we didn't cover when I was talking with the Oregon chapter, and I wish I could see all of you in person, but you're getting to watch me from my beautiful office here at home. But one thing that we didn't cover is how the transitions of care and the changes that are going to happen in reimbursement for 2021, specifically for physician reimbursement, and how telehealth and how we're using telehealth now and how Medicare has defined telehealth, how that is going to impact or can impact the changes in the reimbursement that we're going to see as the E&M coding levels change and we start seeing quality become part of the reimbursement mechanism for physician reimbursement. So we are going to look at what is considered telehealth and what is not considered telehealth. Even during the public health emergency, that becomes very important information. Started my day at 5:30 my time. I love working in different time zones, but started with a hospital on the East Coast and was able to talk with them about their specific scenario and why and how Medicare's current interpretation and what CMS has done with its development of its telehealth policy during the public health emergency, how that can show us intent as to what they plan to do going forward. And again, a lot of that, a lot of what will happen after the public health emergency is speculation, but there are certain pieces that it makes the current regulatory environment and what CMS has done make a little bit more sense. And what the administration is saying is going to happen with respect to telehealth policy after the public health emergency. And then we're going to look at coordinating care across the revenue cycle. So what is and what is not telehealth becomes important to then how we virtually can coordinate and transition care for our patients. So here it is, the big opportunity to join the polling questions. I get a little too excited about my topics, so they throw polling questions in to make me slow down just a little bit. So if you would participate in the poll, we don't gather the information, we don't keep the information, other than it's going to pop up on the screen and we'll all be able to interact and participate. So if you go to pollev.com/nThrive event 968, and you can do that on your computer or your smartphone. Agree to the cookie policy, and you don't have to worry with putting your name in. We don't have to track this for continuing education sub-presentations. We have to, so we don't on this one. And I believe that link was put into the chat box if you want to just click on the link to the poll EV. So here comes our first question. What is transitions of care? And you get a multiple guess option. Is it hospital discharge planning? Is transitions of care hospital case management? Is it nursing home discharge planning? Is it physician office follow-up, or is it all of the above? So let's see how our answers go here. It helps if I use the right mouse as I try to move my face out of the way here. Okay. So far, everybody's saying all of the above. Well, look how smart you are. You don't even have to sit here for the next hour. But we'll have fun with some of the information anyway. So, yes, CMS's definition of, and sorry, I'm going to move my face out of the way again. Pardon me. CMS has defined transitions of care as the movement of the patient from one setting of care to the other. So note it is any setting of care. So that physician office visit to going home from the physician office visit is a transition of care. So it can include all of those areas that all of you are so smart that you already knew. Whether you're going from the hospital to home health, your physician office to home health. Yes, home health can be ordered out of the physician office. The patient does not have to be hospitalized. If you're going from a rehabilitation facility to home and all of those things, that's what the settings can include. So in case you were unaware, put this information in. Medicare did change the conditions of participation with respect to discharge planning. Came about as part of the IMPACT Act, Improving Medicare Post-Acute Care Transformation. The act was back in 2014. And CMS did issue proposed regulations, and under the regulatory guidance, they had 3 years to implement those regulations. As you can see under the proposed rule there, it was proposed November of 15, so they had until November of 18 to issue the final rule, well, they gave themselves an extension. And so the final rule was published and became effective 90 days after publication. So CMS took 3 years to figure all of this out and how we were going to operationalize these new discharge planning conditions of participation, and we had 90 days to comply with that information. So it does apply, these new conditions of participation, not just to hospitals or acute care hospitals. These conditions of participation and these changes apply to LTACs, SNFs, home health agencies, and inpatient rehab facilities as well. CMS said, and it had to do with the Impact Act and what CMS was tasked with by Congress. CMS was to put in place goals for transitions of care that would help healthcare organizations to solicit feedback from the patient and the family with regard to their ongoing care and their transition. Imagine that. We need to include the patient and the family in their care decisions. And again, it's the patient when the patient has the capacity, and including the family when either the patient doesn't have the capacity or the patient has given that authorization that my daughter is my primary caregiver and I want my daughter involved in my care. So we now, under these transitions of care guidelines that CMS put out, that were required under the Impact Act, we have to take into consideration. Well, doing it and documenting it are two different things. So that becomes an important part. Are we documenting that we took into consideration the feedback of the patient? We involved the patient and the family in their decision-making process, including in that hospital transition of care. Medication information has to be clearly communicated. So we're giving that MedRec to the patient as part of their discharge information. When you leave your physician's office from a physician visit, I had to take my daughter to a specialist visit last week, and as we were walking out, the nurse handed us what she called the report card from the visit. Here's your report card from today. And that report card showed we had no medication changes, this was what was going on, and that is part of that communication with the patient. Now, ideally, that communication would not have been, here's your report card as we're walking out the door, but again, met the checkbox requirement of provided the patient and clearly communicated the medication information. And then the goal being we want to reduce 30-day readmissions and reduce preventable visits to the emergency department. And we're going to look at why all of that is important and how telehealth applies to all of that. If ever you can't sleep at night and you want to take a look at all of the recent regulations that impact reimbursement on failed transitions of care, here are just a few. And so we're looking now at, if we do not, we as the providers, effectively transition the care of our patient. And again, I'm not just talking hospital, but if we don't do that effectively, our reimbursement is going to be impacted by this for the services that we do provide. And the regulatory authority comes out of these various programs, including value-based purchasing and the hospital readmission reduction program, the provisions that were provided under the Affordable Care Act. We'll look at a few of those, as well as the 21st Century Cares Act. So as we look at these things, clinical encoding traps. One trap that I don't want us to fall into as we talk about readmissions, and that is one area, the hospital readmission reduction program. We know we get tagged for those readmissions. We're tagged for them, but make sure that we aren't allowing ourselves to fall into the trap that just because it was an unplanned readmission within 30 days of discharge, boom, it's a readmission. Not necessarily the case, so don't fall into that trap. Patients have to be readmitted for the same, if they're readmitted to the same hospital or an other applicable acute care setting, no matter the principal diagnosis. So the rule. But what the requirements actually say is the readmission has to be excess, related, and unplanned and avoidable. That becomes important because the definition of excess looks at our readmission rates as they compare to both national and regional areas. Related, we're going to look at what is a related readmission, and then unplanned and avoidable. So the trap, same DRG, same admitting diagnosis, 30 days, boom, we just have to fall on the sword. Not the case, because even as the QIOs were instructed, the related readmissions, CMS instructed the QIOs that they are to look for and review the record for evidence. Note that all caps there. Evidence of incomplete care, premature discharge, potential presence of a problem that required subsequent care, and we did not adequately follow up on the arrangements as part of our discharge, and cases where the hospital contributed directly to the need for readmission. So in all of these things, if the patient fails to comply and follow up, if our documentation shows that we set the follow-up appointment, we contacted the patient within 2 days of discharge and made sure they understood their discharge instructions, knew that they had that follow-up appointment. We document that we talked to the patient about, do you have a ride? Can you get to the appointment? We did all of these things, and the patient did not follow through. That is not a related and avoidable readmission. So that becomes an important part of this, because as we get into the telehealth, I'm going to show you how we can use virtual services to meet these requirements of documenting and showing that these readmissions that then affect our overall reimbursement may not be related, and they may not be preventable, in that we documented and did all that we could in those scenarios. So the Affordable Care Act did expand what is a related admission, and pretty much said, unless there is clear evidence that the admissions are unrelated, the presumption is they're related. So while the QIOs were directed to look for certain things, the Affordable Care Act said, assumption is, provider, that this was a related readmission. You have to prove to us that it was not. So that is the key information that, as we start looking at how telehealth can help in these opportunities. I also want to take a look at how the changes in the physician fee schedule and the changes for 2021 are going to be impacted by how we utilize telehealth moving forward. So Administrator Seema Verma, I always have to slow down on that name, said that as part of putting out the 2020 physician fee schedule final rule, that we, CMS, want to focus on the time that providers are spending with patients. We want reimbursement to focus on that. So the intent was, CMS, want to encourage the primary care physicians to spend more time doing what? Coordinating care. So there is a method to my madness as to why we're talking about transitions of care in a telehealth presentation. So these physician fee schedule changes say, we want you, primary care physicians, to work with the social determinants of health, increasing patients' adherence to treatment, improving the continuity of care. And oh, by the way, we already told you you needed to be doing this in our transitions of care rules, but now with the assistance of the American Medical Association, we're going to start making your reimbursement actually reflect the fact that this is going to take more time from the physician than what we have expected of primary care in the past. also increasing the importance of the merit-based incentive payment program that we're going to talk about very quickly, as if I talk about anything slowly. So the 2021 physician fee schedule proposed rule. In that rule, so starting January 1 of 2021, which 2021 used to sound a long way away, it's around the corner. Implementing these changes. So this was what was recommended, as I said, by the American Medical Association. So in this physician fee schedule, the final rule, it became final. They are removing the history and exam from the E&M code selection. What this does not mean, it does not mean the physician doesn't have to document history and exam. And that is going to be one of our areas for continued education with our physicians. Just because it isn't part of the code selection doesn't mean it isn't important to the overall documentation for the patient. And what this rule allows is for the option with the physician or the provider to choose either time or medical decision making when choosing the level for the E&M visit. So that is a change starting for January 1 of 2021. So being prepared. Are we getting our physicians on board? Are they understanding that this does not mean you don't have to document the history and the exam? It just means that for the selection of the E&M level, you have the option of time or medical decision making. And this plays into some of the merit-based incentive payment program requirements that CMS also, as required by law, Congress said, CMS, you need to implement regulations that will encourage physicians to adopt electronic health records and a quality reporting system and value-based reimbursement for physicians. So in order to participate in the merit-based incentive payment system, you are required, must participate, if you have billed charges that are more than $90,000 for Part B professional services, or the number of beneficiaries you see is more than 200 Part B patients, and the number of services you provide more than 200 covered professional services to Part B patients. So any provider that fits in that category must participate in the MIPS program that then, as I said on one of the prior slides, looks at promoting interoperability, improvement, cost, quality, and incentivizing physician reimbursement around that. So here we are, all this time in, and we're finally going to talk about telehealth. So what are the opportunities for telehealth within transitions of care in both the inpatient and the outpatient setting? As I said, the definition of telehealth and what Medicare defines as telehealth becomes very important as part of this process, because after the public health emergency, in order for CMS to continue to reimburse for telehealth, and I use quotes around that, telehealth as it is defined by the Social Security Act, Medicare, CMS can only authorize reimbursement for telehealth services under their authority that is granted by the Social Security Act. The reason CMS has been able to issue all of the waivers that we're seeing now is because we're within a public health emergency. So Stafford Act allows these waivers. We could get into the whole history of why they could issue the waivers. They can issue these waivers, but that authority is only granted so long as there is a public health emergency. Well, we know that the public health emergency has been extended through the end of the year. Is that public health emergency going to continue after December 31st? I don't know. Are we continuing to see cases of COVID? Are we seeing hotspots? Are we going to have a vaccine by then? We are going to continue to be dealing with COVID after December 31st. But what that is going to look like from a regulatory standpoint, as we look at we're changing, possibly changing. We have an election coming up. We don't even know what the executive function of the government is going to look like after the beginning of the year. So if the public health emergency is continued after December 31st, then the waivers that CMS has put in place remain important, and how Medicare is allowing telehealth visits. The items that are not defined as telehealth, these virtual check-ins and the e-visits and the other types of virtual services, it becomes very important to recognize that those are not considered telehealth. Reason being is CMS's authority is broad with respect to those services, where it is very narrow with respect to telehealth because of the constraints of the definition of telehealth under the Social Security Act. So your legal lesson 101. So Medicare telehealth services, prior to the public health emergency, we know they were very limited. During the public health emergency, the geography has been anywhere within the public health emergency area. So it is a national public health emergency. So telehealth can be provided anywhere within the public health emergency. Patients can even be located in their homes when receiving telehealth services. That is a key distinction, because if the service isn't considered telehealth, none of this applies. The broad list of services, it's up to over 130 now, services that have been added to the telehealth list. Again, applies to only those services defined as telehealth. And then the technology. Now, the technology that has been allowed to be used, we can use Zoom meetings for our telehealth services during the public health emergency, as long as it is non-public facing and interactive, real-time interactive. I do not anticipate that will continue after the public health emergency. We're going to go back to those tight restrictions where security, and it has to be a secure link and various higher security levels that are required under HIPAA after the public health emergency. That technology area is one area that I would be very surprised if it continues after the public health emergency. But CMS has said that they want to, and the administration has said, we want to continue this vast use of telehealth because we've seen that it provides better access to patients, that it is more convenient for patients. And well, now we've let the genie out of the bottle, and the physicians realize, wait a minute, I can see more patients. I can do more via telehealth. And there hadn't been the incentive for physicians and providers to adopt telehealth because, well, Medicare didn't pay for it. So why would I adopt telehealth when I can't get paid for it? Well, now that the shutdown happened and we were pretty much forced into telehealth, now scaling that back is going to be harder. And so the physician visits, emergency visits, the nursing facility initial admit and discharge, and hospice visits, over 135 services that are part of and included in the telehealth list, again, only during the public health emergency, along with who can provide those services. So key, not limited to rural settings. During the public health emergency, we can provide telehealth to both new and existing patients. We report the CPT or HCPCS code for the telehealth service, but key, the place of service is where the service would have been provided if it had been done in person. So we are not using the place of service of telehealth. That is very important from a reimbursement standpoint. I worked with more than one client that came back and said, we're not getting paid the same amount for these services that we would have been paid had they been done in person. And CMS told us that we were going to get paid during the public health emergency. We were going to get paid the same as if we saw the patient face to face. So we dug a little deeper And come to find out, their system was automatically calculated or calibrated to put a place of service of telehealth on the claim when it went out the door. And that was not stopped. So all of these services were going out with a place of service of telehealth, so the providers were not getting paid as if this was a face-to-face visit. So make sure that you are monitoring how those services that you are providing are getting reimbursed, because the place of service needs to be where it would have been had the service been provided in person. And then you apply the modifier 95 to that telemedicine service to say that it was rendered by real-time interactive audio and video. So that is for our telehealth services. So those are the services that after the public health emergency, it's going to be more difficult for CMS to continue the expansion of reimbursement because of the requirements under the Social Security Act. But there are various services that CMS has said, oh, that's not telehealth. We're not going to consider that interactive visit to be telehealth. So before we get to virtual services, I want to point out one of those because it came up in a discussion I was having with a client just this morning at 5:30 in the morning, very early this morning. So they were talking about virtual ED visits. And in that discussion, we were talking about the fact that they were using interactive equipment. So the provider, it was either physician or advanced practice practitioner, was in a set location, and they were covering multiple or are covering multiple ERs. The equipment that they're utilizing allows the physician to listen to breath sounds, to hear the heart rate, all of these things. There's a nurse and or an MA in the room, but the physician is not present. So we were talking about, and the client's question was, how is that going to look after the public health emergency? What can we do now and what can we do after? Interesting discussion because, well, what you can do now, very broad, under the waivers. As we talked about the opportunities after the public health emergency, a key factor came into play. The provider is located in an administrative building that is on the same campus within and under the same NPI, the same National Provider Identification Number. So same NPI as the outlying ERs. There were 5 freestanding ERs and then 1 hospital-based, I think. But they're all under the same NPI number. Under CMS's guidance, they have said that is not considered telehealth. I'll let that sink in for a minute. So, physician is not face-to-face with the patient. They are using interactive audio video. How is that not telehealth? Well, CMS had the authority or has the authority to say, no, we're not considering that telehealth because they're set under the same NPI. And the physician and the patient are located in the same building or in the same campus, and they defined campus to include the entire NPI number, to include campus. So what that means is if CMS continues that interpretation after the public health emergency, which that is something they do have the authority to do, if they continue that same interpretation, that service isn't considered telehealth. So the restrictions of what's defined as telehealth under the Social Security Act don't apply. So that makes it an interesting interpretation as we look at how CMS has interpreted what truly is telehealth. So those services during the public health emergency where our intensivist wasn't going into every ER, or excuse me, every ICU bay every day. They may have been visiting the patient, and the patient had an iPad in the room and a nurse was in the room, but they didn't want to don the PPE and there was no need. They were looking at ventilator settings and various things, but they weren't hands-on face-to-face with the patient for spread of disease purposes. And that is not considered telehealth. So keep that in mind as to what is actually defined and considered telehealth, even within those services that we would generally consider telehealth. So other services, other virtual services that are not considered telehealth. Virtual check-ins. So these are those brief 5 to 10 minute check-ins. The provider's either using telephone or other telecommunications device, and they're determining, is an office visit necessary? Not face-to-face with the patient. We may be using interactive communication. It may be just approved telecommunications. It may be phone. This is not considered telehealth. The only thing that changed during the public health emergency was CMS broadened and allowed for reimbursement whether this service was provided to a new or existing patient. Previously, CMS would only reimburse this for existing patients. But again, not considered telehealth. So it was in place before the public health emergency. It's going to remain after. Same with e-visits. So e-visits, not telehealth. But these are communications between the patient and their provider through the portal, through an online portal. And they, again, because they're not telehealth, none of the rule setting and geography and any of those requirements are in place and available, again, during the public health emergency only to both new and existing patients. So this is a separately reimbursable service from the E&M visit for the patient, but it isn't considered telehealth. So that transitions of care, continuing to communicate with the patient, there's reimbursement available for this. There was prior to the public health emergency, there is going to be after, because this is not considered telehealth. So looking at other virtual services, I had the question come up, remote patient monitoring and ambulatory or outpatient care management, those aren't on the telehealth list. So can we provide those remotely? Yes, because the very nature of the service itself is it's going to be provided remotely. These are not telehealth services. So looking at what these are, both were in place before the public health emergency, and they're going to remain after. And as we saw in the initial slides with transitions of care, they're actually encouraged because they're intended to improve those outcomes, support that patient-centered environment. The difference between the two, and there is separate reimbursement for these, and they do not have to be, you do not have to be under a care management, chronic care management protocol to receive remote patient monitoring, but remote patient monitoring can be part of a chronic care management protocol. So that remote patient monitoring is the technology that's utilized. Monitoring clinical data. So remote patient monitoring, if my physician makes a change to my blood pressure medication. Thankfully, I'm not on blood pressure medication yet, but let's say I was, and the physician makes a change to my blood pressure medication because during COVID, I'm home more and I'm trapped with my family, so my blood pressure is going up. So my blood pressure is going up and my physician makes a change to my blood pressure medication, but wants to make sure that that change is effective. It's working. So could put me on a remote patient monitoring protocol so that he or she says, Jenny, every day I want you to monitor your blood pressure. And so you're going to send that information in, and that's going to be monitored, and then that information is tracked over time. That's just the data itself. Different than chronic or transitional care management, which is that coaching. that behavior change coaching, identifying some of the social deterrents on health. So looking at a few of the requirements, and we're going to just talk about them briefly, but remote patient monitoring is really the data and communication of the data between your physician visits. So how did Ginny do? I know what Ginny's blood pressure is the day she comes in for each visit, but what is it any other day? And the remote patient monitoring allows that tracking and trending that gives the physician the ability to make better clinical decision making, because they don't just have a snapshot of Ginny's blood pressure is fine today. Where chronic care management is putting together a plan and taking action with that plan. So these slides just give you a little more information about some of the key requirements. Something that is important that changed for 2020, having nothing to do with the public health emergency, but it was a game changer when it came to remote patient monitoring protocols. General supervision is now allowed starting for 2020. What that means under the Incident 2 rules is that the ordering physician, the physician who is ordering the remote patient monitoring, does not have to be in the same location as the staff that is monitoring, that is monitoring the data that's coming in and tracking that and ensuring that Jenny is sending in her blood pressure every day. So the ordering physician does not have to be in the same location and does not have to be the physician that is supervising the staff that is doing that remote patient monitoring. So that's a game changer when it came to the ability of being able to provide the service without each physician and each clinic having their own staff, or the physician having to monitor the data on a hourly, daily, whatever the tracking would need to be for the specific information. So very important change for 2020. Just looking at some of the reimbursement for remote patient monitoring. So we know that our reimbursement is going to be impacted by quality and by our readmissions. And we're now telling physicians, we want you to spend time. And so we're going to allow you to bill your E&M visits based on time. Well, in addition to that, the monitoring that is done outside of that visit is separately reimbursable. So these are just, these are the codes that would be reimbursed, and there are work RVUs available. So that became important as we don't have freestanding physician practices as much as we used to, in that a physician owns their own practice, does their own billing. Most, if I could be so presumptuous, most are employed by hospital systems, and they're paid on an RVU basis. Well, there are even work RVUs available for the minutes that the physician that are billed on a monthly basis, even though the physician is not doing that direct monitoring of the staff. They can have qualified personnel and clinical staff that are watching that dashboard and, you know, sending Ginny a text message or calling Ginny and saying, hey, I don't see that you checked your blood pressure yesterday. What's going on? And Ginny, you've sent in blood pressures twice a day. They're looking good. That type of communication. Key being, we have to have 20 minutes of that interaction with the patient documented in order to bill that 99457. So in any 30-day period, we have to have, or excuse me, in any month, we have to have that 20 minutes of documented interaction with the patient. And the monitoring of, so I open Ginny's dashboard and I'm the tech, and I'm looking to see, okay, she's providing her blood pressures every day. They're looking good. I've sent the data to the physician. I communicate back with Ginny. Everything's looking good. That time counts toward that 20 minutes that then is reimbursable. So we would even have the supplies. So looking at remote patient monitoring, one of the items that is billable is the supplies and the kits. Well, that Bluetooth scale that we want Ginny to weigh herself daily because of her congestive heart failure, and we want to make sure that Ginny isn't slowly putting on weight because, okay, it's COVID. I'll admit my jackets are fitting a little tighter than when I used to be on site at hospitals. But other than the fact that I've put on my COVID-19, if I'm slowly putting on weight and I'm a CHF patient, that's a totally different picture than Ginny's a little too close to the fridge during COVID. So that Bluetooth scale could be reimbursable as part of a supply that's provided under a remote patient monitoring protocol. Checking my time. Okay, so I am running out of time. We're going to get rolling here. Looking at care management as well. If the patient has at least 2 chronic medical conditions, that is when Medicare will pay for this behavior change type coaching. Again, it has to be at least 20 minutes a month, and we can't double dip. The 20 minutes can apply to both remote patient monitoring and chronic care management. Or if the patient has transitional care management, sorry, lost my train of thought. So transitional care management is that 30-day period after I'm discharged from the hospital. For 2020, there was a change that said I can, as the provider, order both transitional and chronic care management during the same 30-day period, and you can be reimbursed for both if you can show 2 distinct services were provided and you met the requirements for each service. So that successful transition from the hospital can be provided under transitional care management for the same patient that is under a chronic care management program. That was new for 2020. Again, some of the key components with transitional care management, this is where that proving that it was not an avoidable readmission. Transitional care management is probably one of your best tools, because in order to bill for transitional care management, there's effort that goes into that, and you can be reimbursed for that effort, but it includes contacting the patient within 2 business days of discharge, making sure that they have a face-to-face visit within 7 or 14 days. That's the complexity. And that interaction with the patient is all required. And as part of that documentation, you would show if we have done all of these things and the patient was still readmitted within 30 days, you have a defense to the fact that that was not an avoidable readmission because we did all we could to prevent it. And sometimes those readmissions happen. You'll get a copy of these slides to be able to look at the codes and the reimbursement along with the work RVUs that are available, again, in addition to the face-to-face visit that is billed as part of transitional care management and or chronic care management. So it starts to look like real money is pretty much what that slide says to us. Consent. I just want to throw this out. Make sure that we are properly getting consent for both the telehealth and the virtual services. CMS has said that can be one consent and it can be done annually, but if we haven't seen the patient face-to-face in the last year and got that consent in writing face-to-face, then we need to get the verbal consent every time we do a visit with the patient. So, question. Is your organization providing these chronic care management, transitional care management, RPM? Are they providing these services? And are you, I'm going to add to the question, are you using them as part of your documentation to prove that a readmission was not avoidable? So looks like we've got everybody using them so far. I'm going to jump ahead here real quick because I want to talk about telehealth in the phased reopening of healthcare. So CMS has given us this phased approach, and we are not going to be able to flip a switch. We were told to shut down, now we're reopening, and we're not going to be able to just flip a switch and go back to normal operations. For one thing, our old normal doesn't exist anymore. So we know we had the public health emergency. In June was really when we started seeing the reopening of non-COVID, non-emergent care. And CMS put out their guidance in April as to that first phased approach. Phase 2 came out after that, but we know for the next 12 to 18 months, COVID is going to be part of our healthcare environment. And we don't want to go back to being shut down, to say, hey, too much of a spike, we're going to shelter in place again, and no one is going to get healthcare services that are not COVID related or not emergent. We don't want to go back there. So we want to build our guidance and our plan on pacing and prioritizing that restarting of healthcare. So CMS put out their guidance and said we need to look at both procedural and chronic disease care first, and ultimately preventative care. So that is the last thing that we are to reopen, is some of our preventative care as part of our pacing and prioritizing. I do a whole different presentation on why preventative care, if we aren't doing that as part of this period during our public health emergency, we're going to have cancers, heart attacks, strokes, things that are going to be the impact of COVID beyond the public health emergency. Yet another topic. The data is there to prove it. But CMS has even said that preventative care, worry about that last. So once we have met our gating criteria and we see that downward trajectory, which some of us didn't see the spike until things reopened, but you've got to continue to see that downward trajectory for CMS to say you can be at phase 1. Many of us are not watching these things that, well, the shelter in place order isn't there anymore, and so we can continue, we're just going to continue to operate. Well, are you watching that data and what's happening in your area? We know our school systems, a lot of them are, but CMS told us as healthcare organizations, we are to do this as well in looking at the symptoms, the cases of COVID-19, and what our hospital is capable of doing. So these are symptoms, cases, and what our hospital is able to do. So watching those symptoms and cases becomes important. Once we've met that criteria, we can start to provide non-emergent, non-COVID related care, or continue to provide that care. But CMS has said, use telehealth. We are still strongly encouraging the maximum utilization of telehealth, as we know the public health emergency is continued, and only provide care face-to-face when it cannot be provided virtually. That is what CMS's guidance is. We know a lot of our patients want to come in and have that face-to-face interaction. What we have to do as the providers is be able to justify the why that particular patient needs the face-to-face visit during the continued public health emergency. Administrator Seema Verma said, patients, you can be competent in seeking in-person care when that is what is recommended by your provider. And the CMS administrator put that back on the providers and said, hey, we told the providers to do this. We've got a phased reopening approach. Patients, you can be confident. CMS is going to put that back and is putting that back on the providers to make sure they say, okay, we are now reopening things. It is up to you to make sure that you're doing so safely. So states and regions that have underlined there, no evidence of a rebound, and you're still meeting the gating criteria, you can move to phase 2 under CMS's guidance, not a requirement, but guidance. So again, make sure we can defend that we're meeting that guidance. So phase 2 is we still have the availability to rapidly deploy alternative care sites, hospitals without walls. We can rapidly respond if there's a spike. We have to be able to do that. and say we have the staff, show that we have a plan to do that, continue to optimize telehealth. So CMS is telling us, even in phase 2, optimize telehealth and evaluate that necessary care that's face-to-face. Essentially, we're to prioritize our services that were deferred during the public health emergency and prioritize the patients that are at highest risk. But make sure they don't get COVID. So we're to prioritize our highest risk patients at the same time that we have to, in our physician practices, keep those patients safe if they're coming into our facilities, whether it's the practice or the hospital. So there is a new CPT code. Again, nothing to do with telehealth here, other than the fact that if you aren't using telehealth, be able to justify the patients that are coming into your facility. And we now have a CPT code that recognizes that when we're now providing face-to-face services, there's a higher amount of supply that is required, and that we had to adopt additional measures to meet those requirements. I'm not going to read these slides, but the guidelines are there because the CDC also put out guidelines for preparing your offices and your clinics for providing the services to patients. And this is the code for the additional supplies and time that is required and allowed now by COVID-19. So it's the 90072. And it represents that, a new practice expense specifically intended for during the public health emergency. So again, it's only during the public health emergency for that increased time, symptom checks, various things that are underway as we see patients in the live environment. And I did include within the slide information, more detailed information on the use of that code. So here is the distinction between the 99070 and the 99072. So the distinction between the two, 072 is to be reported during the public health emergency, and it is additional items that are required to provide the safe and in-person, not our general supplies that are part of seeing the patients in the face-to-face environment. And that 99072, it includes additional time that it may take for our staff that are involved, the additional surgical masks, the cleaning supplies that we have to have in place under the public health emergency. So additional revenue cycle opportunities. So we talked about the additional supply codes that are now available, but keeping in mind we have the chronic care management, transitional care management, and even the development of a care plan and how that care plan can work in better identifying those patients and being able to defend the patients with whom you need to have those face-to-face visits. So on our nThrive, we created a microsite for COVID-19, and we are constantly updating the guidance as it comes out. I have the privilege of sitting on all of the CMS calls, reading the guidance as it comes out, working with our coding staff and my other colleagues within nThrive, and we update the information, and there's detailed information on the coding and billing requirements as they relate to telehealth and other services during the public health emergency. And these slides will be available on that microsite as well, and it's nthrive.com/COVID-19. I think we made it.
Jenny, that was impressive. So much information in such a short period of time. Don't know how you did that. We do have a couple questions, if you don't mind.
I don't mind at all.
The first one, I believe, relates to the readmission policy, and one of our attendees would like to confirm whether that policy applies to a DRG exempt hospital, like a critical access hospital.
So the requirements for a critical access hospital and the readmissions are slightly different, but critical access hospitals are still impacted by the overall reimbursement for the quality, even though they are not reimbursed on a DRG basis. So it doesn't apply the same as it does to a DRG, a PPS hospital, but the overall quality measures and the way readmissions fall within those does apply.
Okay, great. And then this next question is a little bit more detailed here. So can an acute med-surg hospital bill for telehealth patients that are at home and have a telehealth visit with the ED physician? And then what codes would be applicable for which payers? So that's a mouthful there.
That is. Okay, so ask the first part of the question again. It's a med-surg
okay.
hospital.
Right. Can a med-surg hospital bill for telehealth patients that are at home and have a telehealth visit with an ER doc, essentially?
Okay, so you're doing virtual ER visits, essentially, is what that would be, is a virtual ER visit. The answer is it depends. And I'd be happy to actually answer this one online, or excuse me, in writing. But what it would depend upon, and there's several factors. Have you expanded your walls? So has the hospital done, the hospital without walls and expanded their walls to include the patient's home? That becomes one question. If you have versus if you haven't, then that depends on whether or not it is then even considered telehealth. However, you can, ER visits are now included on that list of telehealth services. So the patient, during the public health emergency, the patient can be at home and the ER provider in the hospital and do a virtual ER visit. There are ER visit codes that are available on the list of telehealth services during the public health emergency. And that's one, as the questions are in the chat box, if we want to save those, and then I can answer all of them in writing and send them out to all of the attendees as well, because some of these are getting complex, and I'm more than happy to answer them in writing so that all of the attendees have the answer.
Okay, perfect. And just to confirm, so that virtual visit you just were referring to wouldn't technically be considered telehealth then, or would it?
If the hospital expanded its walls, no. If the hospital has not expanded its walls, then yes, and the hospital could bill a technical component. Of course, the ER, it would depend, is the physician employed, are they contracted, who does the billing, the assignment of, there's a lot that is involved in that. But it would be considered a telehealth service if the patient and the physician are not located under the same provider number, or the hospital has not expanded their walls.
Great, so it depends on a lot.
It depends. That is my answer. It depends. But again, my email address is also going to be in the, I think there it is. Okay, and feel free, if it is a very specific question, you can send me an email as well. But yes, so the answer on that is it depends, but yes, it could.
Okay, perfect. And then one final question here is, you're quoting 12 to 18 months for this to be ongoing. If you're looking into your own COVID crystal ball.
Okay, I've got my crystal ball, my cup.
With all of these modalities for virtual, quote unquote, virtual e-visits, telehealth, a lot of planning, administrative resources, time has to go into, like you said, coordinating all of this. Strategically, our hospitals don't have a lot of resources to begin with, and with obviously the significant reduction in revenue, there's not a whole lot of bandwidth to prepare. So I guess not to put you on the spot, but where should we be devoting our time in planning for what's to come?
Great question. What do we know versus what do we not know? What's still unsure? The things that we know are the items and services that are not considered telehealth are reimbursable now, and they'll continue beyond the public health emergency. So have we maximized, and CMS did a study and it showed that less than 20% of eligible beneficiaries that they felt would be appropriate for a chronic care management program, less than 20% of them were enrolled in a chronic care management program. Now, were they not enrolled in it, or are we not billing for it? And had a very, very good question come up from another client because they're already part of an ACO and the CMS shared savings program. And they said, well, we didn't think we could bill for chronic care management because we're already part of a shared savings program. Isn't that double dipping? It's not. Because shared savings is that overall savings amongst that entire classification of patients, where chronic care management and the reimbursement that's available there is some of your highest risk and targeted patients, but also making sure that you are including not only your most non-compliant and highest risk patients in your chronic care management program, because they take a lot of time. And, it's that value to time, the time and value. There are some patients that just need a little push, a little encouraging, and include those patients in your population as well, because it also helps with your patient satisfaction scores. So those are some of the things that I would say, focus on what we know is going to continue and we know can have an impact on increasing our reimbursement. If we put time and effort into establishing some of these transition programs that we can be reimbursed for, there's the cost of implementation can be recouped, and it can boost some of the reimbursement that we've lost during the public health emergency.
Absolutely. Well, again, thank you so much to you, Jenny, and to nThrive for supporting HFMA and sharing your expertise. This is going to be a long road here, so I'm sure there will be more things to come that are relevant, and we'll look to you to share that expertise down the road. I'd like to also take this opportunity to also, again, thank our Region 11 sponsors. Without your sponsorship, we wouldn't be able to host this webinar, so I appreciate your continued support. Again, we will send out a survey link. Please share your feedback on how we can improve our education, especially during this pandemic. And I hope that everybody has a great week. Thank you, Brianna, for setting this all up as well. Take care, everybody.
Thank you, everyone.